In chapter 24, we are going to talk about the treatment used in congestive heart failure. A lot of this material should be very familiar to you all as we covered it in cardiopulmonary, but we're going to dive into the pharmacological aspects of treating congestive heart failure here, but the main mechanisms of cardiac heart failure should be relatively familiar to you. Congestive heart failure. So congestive heart failure, or CHF, as you all know, is a chronic condition in which the heart is unable to pump a sufficient quantity of blood to meet the needs of the peripheral tissues. So essentially the heart's pumping ability has been compromised by some form of myocardial disease or some type of dysfunction. The primary symptoms, as you all know, are peripheral edema and decreased exercise tolerance. And the congestive aspect of heart failure arises from the tendency for fluid to accumulate in the lungs and the peripheral tissues because the heart is unable to maintain proper circulation. So remember, if we're having left-sided heart failure, we're going to get pulmonary edema, versus if we're having right-sided heart failure, we're going to get systemic edema. It's usually going to localize to the lower extremities, and we see edema in the ankles. Dyspnea and shortness of breath are also common in congestive heart failure, especially if the left side of the heart is failing and pulmonary congestion is present. Cyanosis can also develop if the heart cannot deliver sufficient oxygen quantities to the peripheral tissues. So you as physical therapists will often treat patients with heart failure, so you should all be aware of the drugs that are used to manage this condition and how these drugs work. So in general, these drugs work by increasing the myocardial pumping ability. And this is really important for physical therapy because the increase in myocardial pumping ability will allow the patient to participate in their physical therapy. The mechanisms that underlie congestive heart failure are very complex, and there is a whole plethora of them. And some of them may exacerbate or antagonize others, causing a stronger effect. So these may include different types of biochemical disturbances in the cardiac cell itself. There may be some type of alteration to the epigenetic or genetic expression of myocardial proteins. There could be a hemodynamic imbalance, and there could be some type of imbalance with neurohormonal factors as well. All the diseases that we talked about before, such as ischemic heart disease, myocardial infarction, valvular dysfunction, and hypertension, all compromise the heart's pumping ability. The neurohormonal activation compensations you should all be familiar with at this point. What I'm referring to there is the activation of the sympathetic nervous system and the activation of the renin, angiotensin, aldosterone system, which we've covered previously, and we're going to reiterate in this talk as well. The increased cardiac workload is caused by peripheral vasoconstriction that happens throughout the body, specifically in it definitely happens in the heart, but it does occur throughout the body as well. I want you to be aware of that factor. And there's also, with the increased cardiac workload, this is also caused by an increase in sodium and water retention. This increase in sodium and water retention puts additional stress on the heart by increasing both the cardiac preload and the cardiac afterload. So everything I just said is drawn on this chart here. It's just a vicious cycle. So if you have this decreased cardiac performance, there potentially may be some type of neurohormonal compensation. This is going to increase cardiac outload or cardiac workload. This could alter the structure of the myocardial cell itself, and therefore in turn cause a systemic effect to decrease cardiac performance and cause damage to the heart. So this is a vicious cycle that, as the congestive heart failure condition progresses, it just gets worse and worse because the body's trying to compensate for all this dysregulation. So when there's congestion in the heart is essentially unable to push the blood forward through the circulatory system. And the blood is essentially going to begin to back up in the venous system, and this is going to increase the pressure gradient for fluid to move out of the capillary beds. The pressure is going to build up in the veins that are returning the blood to the heart, and they're going to cause a lot of additional stress to the heart. The net movement of fluid out of the capillaries causes the edema or the congestion that's typically found in the advanced stages of heart failure. So you all should know the differences between left and right-sided heart failure at this point, but I'm going to reiterate them because this is a very important topic and concept for you all to know. So again, in left-sided heart failure, what's happening is both the left atrium and the left ventricle are unable to handle the blood that's returning from the lungs. This is going to cause pressure to build up in the pulmonary veins, and the fluid is going to accumulate in the lungs. And this is why left-sided heart failure is associated with pulmonary edema. And the opposite's happening in right-sided heart failure. In right-sided heart failure, the right atrium and the right ventricle are the ones that are unable to handle the blood returning from the systemic circulation, and this is going to cause the fluid to accumulate in the peripheral tissues, and you're going to see the ankle edema, you're going to see the organ congestion, especially in the liver and the spleen, and this could be very detrimental to the patient. So these are some signs that you should be able to recognize as a physical therapist, especially with the ankle edema and the distended neck veins, the distended jugular vein, which we've talked about before. So the goal of the pharmacotherapy in treating congestive heart failure is to improve the heart's pumping ability. And the drug therapy should increase the cardiac contractile performance and produce a positive inotropic effect. Inotropic refers to the force of muscular contraction. So a positive effect is going to increase the force of muscular contraction. The primary drugs used to exert a positive inotropic effect are the cardiac glycosides. The primary one I want you to know is digoxin. Dr. Nuzzo also mentioned this in cardiopulmonary today. We're going to talk about different classes. We've already mentioned a lot of these classes before, so a lot of this should be very familiar. I'm going to add on some more detail that I want you to know about these particular classes. The ACE inhibitors, these are the pril drugs. So they have the suffix pril, P-R-I-L. They include drugs such as captopril, lisinopril, benzapril, so on and so forth. The beta blockers we've talked about extensively. Those are the drugs with the suffix olol, O-L-O-L. And then the diuretics, I talked about the different classes of the diuretics depending on where they worked. We have thiazide diuretics, we have the potassium-sparing diuretics, so be sure that you know where in the nephron these different diuretics work. Why do we use potassium-sparing diuretics in patients who may suffer from hypokalemia? Really important concepts to know. And we're also going to talk about the vasodilators. So remember, the primary go-to vasodilator is going to be that sublingual nitroglycerin, but we're also going to talk about vasodilators that inhibit phosphodiesterase 5. These are going to be the vasodilators such as Viagra, which you all should know as sildenafil. So Viagra was initially engineered to treat congestive heart failure and other cardiac complications, but the engineering team found out that it elicits other systemic manifestations and causes peripheral vasodilation. So they marketed it for another use, which is erectile dysfunction. And it's been a multi-billion-dollar industry, and a lot of the other drugs that were developed to treat erectile dysfunction, such as Cialis, kind of piggybanked off of Viagra's idea with the peripheral vasodilation. So whoever invented Viagra is just sitting on billions and billions of dollars right now. The Digitalis glycosides are digoxin and digitoxin. The only one I want you to know is digoxin, D-I-G-O-X-I-N, because this is the only one that's available in the US. We don't use digitoxin in the US because of the terrible side effects associated with it. Digoxin decreases the symptoms of heart failure, and the way it does that is it increases the myocardial contractility by elevating intracellular calcium levels and facilitating the actin-myosin interaction in the cardiac cells. It also has the capability to inhibit the sodium-potassium pump on the myocardial cell membrane. So the inhibition of the sodium-potassium pump causes sodium to accumulate within the cell. So as sodium accumulates in the cell, well, then it has to be stored somewhere. It's going to be stored in the sarcoplasmic reticulum. And the more calcium that gets stored in the sarcoplasmic reticulum, well, it has to be released at some point, right? The sarcoplasmic reticulum can only handle so much calcium. So as the sarcoplasmic reticulum starts to clear out this calcium and release this calcium during each action potential, this initiates a greater actin-myosin interaction and a stronger cardiac contraction. So that's how it's actually contributing to strengthening the heart. It also has digoxin also has the capability to inhibit sympathetic stimulation, therefore lowering heart rate, lowering the stress that's put on the heart, and is very effective in patients with systolic heart failure and atrial fibrillation. The whole idea behind inhibiting the sympathetic stimulation will help to normalize the cardiac excitation and the excessive contraction that may be occurring. Digoxin also has the capability to cause reflex stimulation of the vagus nerve, therefore slowing heart rate and vagus nerve conduction even further, conduction of the heart even further. So again, I'll repeat that. The digoxin has the capability to cause reflex stimulation of the vagus nerve. So it's going to slow heart rate and conduction of the heart via the mechanism it elicits on the vagus nerve. So I mentioned it's effective in patients with systolic heart failure and atrial fibrillation. So digoxin can help to improve the function of the left ventricle and normalize the heart rate in patients with reduced ejection fractions. And please note it's usually used in combination with the diuretics, the ACE inhibitors, and the beta blockers. And each individual treatment regimen is tailored to the particular patient depending on what conditions and comorbidities the patient's currently suffering from. Digoxin toxicity is a fairly common problem and can be fatal. So there are a lot of symptoms that I want you guys to be aware of that could happen with patients who are taking digoxin. So there are a lot of GI symptoms and there are a lot of central nervous system effects that can occur. So Digitalis toxicity can induce both these effects and it can cause arrhythmias. So to prevent Digitalis toxicity, usually what's prescribed is a low drug dosage, and this should be maintained if possible to keep the patient on as low a dose as possible. But again, this is going to be managed by the MD. But if you as a PT notice any of these GI or CNS symptoms happening, signs or symptoms happening, it's really important to communicate with the MD at this point. You should suggest to the MD to make sure that he or she is looking at the plasma levels of Digitalis to see if there's a potential for decreasing the dosage. Now let's move into the phosphodiesterase inhibitors, or the PDE inhibitors. These include inamrinone and milrinone. So the suffix rinone will help you characterize and classify the two most important phosphodiesterase inhibitors that I want you to know. These drugs are usually limited to the short-term treatment of patients with severe congestive heart failure, and it's also used in patients who are awaiting heart transplantation. They are positive inotropic agents. They're usually administered intravenously. And what they actually do is they inhibit the phosphodiesterase enzyme that breaks down cyclic AMP in the cardiac cells. So the cyclic AMP concentrations in the cardiac cells will then increase, and then they will act on the membrane calcium channels to allow more calcium to enter the cell. So both of the drugs that I listed, inamrinone and milrinone, cause a cyclic AMP mediated increase in calcium, which subsequently increases the force of contraction in the myocardial cell. Phosphodiesterase inhibitors also have vasodilating properties. So if there's vasodilation, essentially what we're going to get as far as a positive effect goes is we're going to get a decrease in both preload and afterload. So therefore lowering the stress on the heart. However, you really have to be careful with what types of patients use phosphodiesterase inhibitors. And I know this isn't the PT's role, this is more on the MD, but think about vasodilation for a second. So vasodilation can lead to a decreased arterial pressure and decreased perfusion of the heart. And also vasodilation and the decreased perfusion to other organs, such as the liver and the spleen, could be very detrimental in patients with low cardiac output. So it actually may be counterproductive in these patients. So again, these aren't going to be the main go-to method. They're usually used in advanced stage congestive heart failure if the patient's not responding to other types of medications. Other drugs that are used to treat congestive heart failure include dopamine and dobutamine. They both elicit a positive inotropic effect by stimulating the beta-1 receptors on the myocardium. So they are beta-1 receptor agonists. They're facilitating a response. The positive inotropic effect, we're making the heart work. We're not inhibiting the heart. And again, both dopamine and dobutamine are going to be used in patients with severe cases or very progressive cases of congestive heart failure who don't respond to the typical agents or the first-line defense treatments. They're not typically used because of the adverse effects, the accelerated heart rate. They can induce arrhythmias, they can cause flushing, lots of other complications. So they're typically used as a last resort to sustain cardiac output in specific cases of advanced heart failure. Can also use drugs that affect the renin angiotensin aldosterone system to treat congestive heart failure. So the activation of the renin angiotensin aldosterone system will lead to the increased production of aldosterone, which further stresses the cardiovascular system by increasing both salt and water retention. So luckily we have several drugs to deal with the abnormal activation of the renin angiotensin aldosterone system. The first ones I want to talk about are the ACE inhibitors. So remember, the ACE inhibitors block the conversion of angiotensin 1 to angiotensin 2. And remember, angiotensin 2 is a potent vasoconstrictor. So ACE inhibitors limit the vasoconstrictive effects. And they also decrease cardiac workload by decreasing the cardiac afterload. Therefore, they ease the strain on the failing heart, which results in improved cardiac performance and increased exercise tolerance. Another really cool factor about the ACE inhibitors is their capability to prevent the abnormal vascular remodeling of the heart structures and the detrimental effects to the myocardial vasculature that's induced by angiotensin 2. So remember, angiotensin 2 promotes aldosterone secretion for the adrenal cortex. Aldosterone's going to increase renal sodium reabsorption with a subsequent increase in water reabsorption. So if you inhibit this, you give a drug that inhibits the RAA, the vascular fluid volume does not increase and does not add stress to the failing heart. Another thing that the ACE inhibitors have the capability to is increase bradykinin levels in the bloodstream. Bradykinin is a potent vasodilator, and increased levels decrease the cardiac workload. We're going to talk more about the angiotensin 2 receptor blockers and the direct renin inhibitors on the next slides. So if we get this increase in bradykinin levels in the bloodstream, that's going to prolong the vasodilating effects within the vasculature. The angiotensin 2 receptor blockers that I want you to know are the sartans. So if they have a sartan suffix, candesartan, losartan, valsartan, these are all angiotensin 2 receptor blockers. So they inhibit the angiotensin 2 induced damage of the cardiovascular system by preventing angiotensin 2 from binding to the receptors on the vascular tissues. And these drugs are usually used in combination with ACE inhibitors to produce a very profound effect in congestive heart failure. They're usually used as an alternative for people who are unable to tolerate the traditional ACE inhibitors. So they may be used with some alternative ACE inhibitor, or they may be used with some type of diuretic. The profound effect that I mentioned by combining these two is very controversial, as some papers are actually saying that it is actually, when they're used in combination, it's actually increasing the stress on the heart. And a lot of patients really don't tolerate the combination very well. So the main thing I want you to know about the angiotensin receptor 2 blockers, I want you to know the sartan suffix and the mechanism. They prevent angiotensin 2 from binding to the receptors on the vascular tissues. We also have direct renin inhibitors, which are used in congestive heart failure. And these drugs inhibit renin's ability to convert angiotensinogen to angiotensin 1. So, as you can imagine, by decreasing the production of the precursor substance that's needed to produce angiotensin 2, we inhibit the activation of the renin-angiotensin-aldosterone system. The only renin inhibitor that's really used in the United States is aliskiren. You may hear it referred to in the clinic as Tecturna, but I want you to know aliskiren is the only direct inhibitor that's approved, direct renin inhibitor that's approved for usage in the United States. And these are typically not used, as there are a lot of side effects associated with direct renin inhibitors. So there's a lot more research that's needed before we move to this as a primary treatment. And again, I'm going to reiterate the importance of the beta blockers. So again, they have the capability to block the effects of epinephrine and norepinephrine. They are predominantly beta-1 receptor antagonist on the myocardial cells of the heart, the myocardial membrane specifically, and these drugs help to normalize the sympathetic stimulation of the heart and help reduce heart rate. So these drugs actually elicit a negative chronotropic effect. They also decrease the myocardial contraction force, so they have a negative inotropic effect. They can be used alone or combined with the other drugs which we mentioned. I mentioned the mechanism of activity, as they block the beta-1 receptors on the myocardium of the heart. They prevent angina by reducing the cardiac workload, and they also have the capability to prevent certain arrhythmias by stabilizing heart rate. I do want you to know the two drugs listed in the bottom right-hand corner box, known as the third generation beta blockers, carvedilol and nebivolol. Both of these drugs block the beta-1 receptors on the heart, but they also block the alpha-1 receptors on the vasculature. So they have the capability to cause peripheral vasodilation as well. So again, the third generation beta blockers block the beta-1 receptors on the heart, but also block the alpha-1 receptors on the vasculature. So vasodilation of the peripheral vessels could further reduce myocardial stress by decreasing the pressure that the heart must work against in the peripheral vessels, which is also known as cardiac afterload. The diuretics increase the excretion of sodium in water. So they work by, this is the mechanism of action that I want you to know for the diuretics. They work by inhibiting the reabsorption of sodium from the nephron, which in turn decreases the amount of water that is normally reabsorbed with sodium, leading to increased water excretion. And they're used in patients with congestive heart failure because of their ability to reduce the congestion in both the lungs and the peripheral tissues by excreting the excessive fluid that's retained in these tissues. And this overall effect reduces congestion caused by the fluids retained in the body and decreases cardiac preload by excreting the excess of fluid within the vascular system. So the diuretics have the ability to decrease preload, and hopefully you get the effect of a decreased afterload from the diuretic usage. And as we talked about previously, they're also used to treat hypertension. So they're really good in the hypertension management as well. Where in the nephron do the particular diuretics work? Well, I want you to go back to that slide where I talked about the loop diuretics versus the diuretics that are used in patients suffering from hypokalemia. So I want you to know the loop diuretics, but what they do is they reduce the fluid overload in the nephron, and by reducing the fluid overload, they help alleviate some of the symptomology associated with congestive heart failure. The side effects of the diuretics include disturbances in fluid and electrolyte balances, which can directly affect directly affect cardiac excitability, and the cardiac excitability could precipitate, the excessive cardiac excitability could precipitate arrhythmias. So again, the side effects, the fluid and electrolyte imbalances, and the increase in cardiac excitability, which may precipitate arrhythmias. And last but not least, we have the vasodilators. So these work to reduce the peripheral vascular resistance and reduce the amount of blood returning to the heart, also known as preload. If we reduce preload, hopefully we get a reduction in afterload as well. So both the reduction of preload and afterload should help to alleviate some of the stress on the failing heart and also help to slow the progression of congestive heart failure. So the vasodilators I want you to know are prazosin, hydralazine, and the organic nitrates. So remember the organic nitrates I talked about: nitroglycerin, isosorbide, dinitrate, mononitrate, and sodium nitroprusside. I want you to know all of those drugs. I do want you to know nesiritide. Can never pronounce these words. Nesiritide. Nesiritide is usually given intravenously and is actually derived from the human B-type natriuretic peptide. And when it's given intravenously, it produces both arterial and venous dilation in people with acute or severe heart failure. And remember, the BNP is a natural occurring substance that's released from the ventricles when the heart is subjected to increased blood volume and pressure. So the dilation of the peripheral arteries and the veins helps to reduce the cardiac preload and afterload. And I know I keep saying the reduction of cardiac preload and afterload, but this is a really important concept for you all to know. And when I repeat things, it's for a reason. So let's talk briefly about Viagra, but the name I want you to know is sildenafil. Viagra or sildenafil is a very potent phosphodiesterase 5 inhibitor. And what that does is it prolongs the effects of cyclic GMP in the peripheral vasculature, resulting in relaxation and vasodilation. And as you all know, sildenafil is the primary treatment for erectile dysfunction. Side effects of the vasodilators include headache, dizziness, hypotension, and orthostatic hypotension. So again, with these slides, the special concerns for rehabilitation patients, I'm not going to read this slide for you, but I definitely want you to take some time and read through it. And this particular case study, again, this is not going to be graded. This is not for any type of points, but you may see a similar vignette on the upcoming exams and final exams. So I highly recommend going through this case study and addressing the 3 questions at the bottom. The practice questions, this is going to be the first of the practice questions which I want you to do and compile into a document to upload, but I'll give you more details about this later in the week. Go ahead, try this practice question as well as the practice question on the next slide.